Next speaker is Dr. Om Prakash. He will be delivering a talk on patient with artificial heart valves for an incidental surgeries. He has 5 publications, 5 papers and 5 poster presentations under his name, and he has been awarded for this one presentation called Unusual Lesion Around the Aortic Root and Identification of Using a Real-Time 3D Echo. And he's also awarded the best paper presentation in TE workshop in PGI JIPMA in 2013. And he's a member of the Society of Pediatric Cardiac Anesthesia and Congenital Cardiac Anesthesia Society, and is a peer reviewer of Indian Journal of Anesthesia. I welcome Dr. Om Prakash to deliver the talk on this topic, sir.
So, as an anesthetist, irrespective of the lesion, our objective is always simple. It is to ensure oxygen delivery to the tissue. So, the most important thing in that is we have to know the deep understanding. We should have a deep understanding about the natural history of the disease. We should know where we are in the natural history of the particular disease, and also the physiological changes that is going to happen due to the surgery. And in between, we have to anticipate the complications also. That's when we'll be able to ensure that oxygen is delivered to the tissue. So we frame a anesthetic goal, right? So our topic is basically the primary pathology is prosthetic heart valve, and along with that we are going to discuss about the incidental surgery. The spectrum is very wide. So what I am going to do is I'm going to discuss about the natural history of the patient with the prosthetic heart valve, and then the focused assessment of the valve and the physics behind that and the preparation of the patient. So before that, there are some caveats which I want to tell about the prosthetic heart valve. Basically, all prosthetic heart valves are mildly obstructive and regurgitant. So we have to always try to rule out whether it's pathological, and imaging is very difficult because of the artifacts and shielding. So we need multiple angles and off-view angles to assess the valve. And importantly, we should also do transthoracic as well as transesophageal echo to have a comprehensive idea about the prosthetic valve. And there is a role of fluoroscopy, CT and MRI in case of emergency. So coming to the prosthetic heart valves, they are broadly classified into 2 types. One is mechanical heart valves, and the other one is bioprosthetic heart valve. The most important thing is they are highly thrombogenic, they require anticoagulant throughout, and at least in case of bioprosthetic valve, we should be on antiplatelets. The another most important thing, irrespective of anything, we have to be damn sure about one thing, that is we have to maintain the oxygen demand supply all the time, because our primary pathology is cardiac pathology. So, coming to the natural history. The natural history of the prosthetic heart valve stems from the natural history of the valvular heart disease. We know any valvular lesion will cause pressure or volume overload, which in turn causes the wall stress, and which causes the compensatory changes to maintain the cardiac output. That is the concentric hypertrophy or eccentric hypertrophy, depend on the load. And in turn, which causes the pressure overload, will cause heart failure with preserved ejection fraction for some time. And in case of volume overload, there will be a low cardiac output. That is the heart failure with reduced ejection fraction. Sooner or later, they will worsen. The most important thing is the myocardial injury. Okay. So where we are going to intervene, determine the further prognosis. So for example, if we intervene somewhat prior to the mechanical myocardial injury, our prognosis is going to be good. But if it happens then after the myocardial injury, then the prognosis is really bad. So we are going to have a spectrum of patients where they will have a better prognosis. That means they will recover. But there is another spectrum where the patient is going to perform poorly. So coming to the natural history of prosthetic valve, so we have 2 subset of patients, right? 2 problems here. The one with the existing the valve disease. So the remodeling, the functional status is going to influence the natural history. And another one is, as such, the prosthetic valve itself has got inherent problems like anticoagulation, hemolysis, infective endocarditis, valve dysfunction, and so on. So The most important thing in natural history is assessment. So assessment starts with clinical history and examination. That's what prompts us further investigation. So we may encounter three different subset of patient when we encounter a patient with prosthetic heart valve. For example, first kind of patient is they will be symptomatic initially. They get operated, the symptom will get relieved. Then sooner they will be symptom free for some time. So that means like valve is functioning properly. That is cardiac remodeling is likely. That means we are on the good prognosis side. So the another subset is they will get relieved of symptom early, but sooner or later they will develop symptom. Here there are possibilities are there like valve is getting malfunction or the myocardium is getting get hit. Okay, the another subset is from the beginning they are symptomatic. That is valve from the beginning is not working or the myocardium is already, the damage is done already. So these are all the problematic patients when we come across, we have to really address them and we have to assess them properly. So how am I going to assess them? So the most important thing is echocardiography. So we are going to assess the 2D echocardiography will give us some pertinent signs about the valve lesion and also the Doppler parameters like peak, velocity, mean pressure gradient, effective orifice area, and quantitative flow assessment. I'll try to explain them the physics behind it. So it may look a little bit difficult. So the most important thing in 2D echocardiography, what I am interested is the pertinent signs. What is meant by pertinent signs? Because every lesion will develop some kind of changes in the heart. For example, post-transplant, for example, post-replacement, valve replacement, for example, in mitral stenosis, they generally used to have LA dilatation, pulmonary hypertension, and RV dysfunction prior to the valve replacement. After replacement, if it's of good prognosis, they used to regress. But if they persist, these pertinent signs, if they persist, they warn us. They become a warning sign for further evaluation. For mitral stenosis, it's more of severe pulmonary hypertension if persists even after valve replacement. And for mitral regurgitation, if the LV dimension remains the same and there still the LV dysfunction persists. And for aortic stenosis, so there will be a concentric LV hypertrophy. And for aortic regurgitation, we will have eccentric hypertrophy. If these changes still persist, then it prompts us and they become a warning sign for further evaluation and that we are handling a dangerous patients. So, what are the warning signs we are going to look for? Still the LV dysfunction is there, or there is secondary tricuspid regurgitation due to RV dysfunction, and there is severe pulmonary hypertension still persists after replacement. And what about the chamber remodeling, whether it still persists with the baseline or it's happening, and the LA size and atrial fibrillation. Okay, so what did they tell us? They tell us the extent of myocardial injury and the prosthetic valve function. These are the predictors of the outcome and the prognosis. So coming to the physics behind. See, when a flow encounters a stenosis, what happens is the potential energy decreases and it is translated into the kinetic energy. Why I'm talking about this is because we assess every valve on based of the mean pressure gradient. If the mean pressure gradient is very high, that means the stenosis is high. So now the question is how to measure mean pressure gradient. So when we know how much is the kinetic energy, we can extrapolate it to the pressure gradient. So more the pressure gradient is, more severe is the stenosis. So we use the Bernoulli's principle here. So here, if we know the velocity, we use continuous wave Doppler to measure the velocity. Once the velocity is measured, we use the Bernoulli's. We use the Bernoulli's principle here to measure the pressure gradient. Pressure gradient is nothing but the pressure difference. So there is one caveat. See, it's all related to the flow. If the flow is reduced, it will underestimate your stenosis and the pressure gradient. So you should always ensure when you measure the pressure gradient, the flow is adequate. So next thing is with the help of velocity, I'm going to measure a velocity time integral. It is nothing but, see, when the blood flows, RBC flows, we measure the velocity here. So with the integral formula, so we can measure the distance traveled by the RBC. Okay. So we can extrapolate it to an area. If we measure the entire area of blood which is traveling for the particular time, that is, then we can calculate the volume for the particular beat. So that's how we calculate the stroke volume. Okay. So this forms the basis for continuity equation. That is, if I know the LVOT area, which if I can measure the LVOT diameter and if I calculate area pi r square, and if I know the VTI, so I can measure the stroke volume. So according to the continuity equation, the stroke volume through the LVOT for the particular beat will be same when it passes through the prosthetic valve, right? So if I know the VTI of the prosthetic valve, I can easily calculate the effective orifice area of the prosthetic valve. So there are many times we may not be able to measure the LVOT area properly. That always becomes a problem. That's when comes this dimensionless index, where we try to take the LVOT area of the equation. So what we try to do is, here the concept is simple. When the blood flows through a prosthetic valve, the velocity increases actually. Okay, so the increase in the velocity is directly proportional to the stenosis in the valve or the narrowness of the valve. Okay, so the normal, the velocity ratio between the LVOT velocity and the prosthetic valve velocity is more than 0.3. If the velocity in the prosthetic valve is too high, the ratio decreases. That means what? Your valve is having problem. If the flow is very high, the LVOT velocity also will be equal and the prosthetic valve velocity also be equal and the dimension index maintains the same. So with that, you can easily extrapolate whether the valve is having the problem, whether there is a high flow. So this helps us to differentiate between the valvation. So now you have to remember this formula, that is, pressure gradient is directly related to the flow and inversely related to the area. So that means if the pressure gradient is going to be high and if your flow is normal and the prosthetic valve function is normal, then the valve is becoming small. That's why your pressure gradient is high. That is having some problem. This is called patient prosthetic mismatch. Valve is functioning good, but still your pressure gradient is high for the patient for the normal flow itself. That means this is called patient prosthetic mismatch. But if your pressure gradient is high, valve functioning itself is affected, that's when you have a problem with the valve. Okay? So this is an example how to assess an aortic valve, prosthetic valve. So first thing what we see is, if you see an abnormality in the, there is a velocity has increased more than 3 meter per second, that is your pressure gradient is more than 40 millimeters of mercury, then I go with the DVI. Let's see this limb actually. So if the DVI is slightly on the reduced side and there is a normal, and if you see the valve function is normal, that means your early peaking is there, then it is, the valve is normal. Okay, but it could be due to patient prosthetic mismatch. So coming to the patient preparation, we have n number of problems with the patient. So I'm going to concentrate only the anticoagulation management. So here the problem starts with bleeding and thrombosis. So the anticoagulation forms the basis for the management. Okay, so here if you see, if the bleeding risk is mild, I can proceed with the surgery. If bleeding risk is more, I'm going to stop oral anticoagulation agents. So then the problem starts with the thrombosis. So you have to know if there is high risk of thrombosis, then you have to bridge the patient with any other agent. If it is mild, you can consider proceeding with the surgery. So the bleeding risk, first we'll address the bleeding risk. The bleeding risk is nothing but when the blood loss is causing more than 2 grams per loss of hemoglobin, requiring more blood transfusion, and there is difficulty in controlling bleeding. So the bleeding risk not only depends on the procedure, it also relates to patient-related factors. So here the Tassour et al. Has shown there is a bleed map. These are all the patients who can have a bleeding risk, platelet count less than 1 lakh, mitral mechanical heart valve, active cancer, history of previous bleeding. See, when there is a high risk of patient-related factor, then bridging will cause increased bleeding. Okay. So coming to the surgical related factor, what we commonly use procedures or also has high surgical risk. So we have to consider this factor. Coming to thromboembolism, these are all the risk factors for thromboembolism. High risk factors, that is atrial fibrillation, mitral and tricuspid prosthetic heart valves, previous history of thromboembolism, and LV ejection fraction of less than 35%. So what did they say? This is the mechanism behind that. Blood stasis or hypercoagulable state can cause high risk for thromboembolism, and the valve also, it depends on previous older valves like cage ball valves or high thrombogenic, so they can also has increased risk of thromboembolism. So coming to the bridging, now the question is, we are going to use heparin for bridging. Which is the choice? So low molecular weight, the recent meta-analysis has come up with the finding that low molecular weight heparin are best choice for non-cardiac surgery patients. So this is the way I'm going to bridge my patient. So this is like high bleeding risk patient with high thromboembolism risk. So what we are going to do is, we are going to stop warfarin 5 days prior. Once the therapeutic level drops, we are going to start low molecular weight heparin. So ideally, we can use enoxaparin 1 to 1.5 milligram per kg OD, and at the day of surgery give 0.5 milligram, then do the surgery, then cover the patient with venous thromboembolism prophylaxis, and day 1 as early as possible try to start warfarin, that is after 24 hours ideally speaking. So once they can take oral feeds, so start heparin, and as well as try to bridge them till they reach the therapeutic level. So post-operatively you can do that. So this is 2 in 2 box, same thing which I have mentioned. So coming to the pregnant patient, so if you see in the pregnancy, so the therapeutic anticoagulation monitoring is very, very must, and it has to be maintained at the therapeutic range for the patient with pregnancy. If they are not able to maintain the therapeutic range, please advise them to terminate the pregnancy. Okay. And the vitamin K antagonists are the best drug, and but the only problem is the fetal miscarriages or fetal loss. Okay, if patient requires more than 5 gram of warfarin throughout the pregnancy, so what we have to do at the week before surgery, we have to change it to low molecular weight heparin. Our therapeutic goal should be around the anti-10A factor level of 0.8 unit to 1.2 unit per ml after 4 to 6 hours of the therapy. Or if you are giving unfractionated heparin, you have to maintain APTT of 2 times. And 36 hours prior to the surgery, you have to change it to unfractionated heparin. And 6 hours prior to the planned vaginal delivery, you have to stop the heparin. And the green color says it's a class 1 recommendation. And if the patient is taking more than 5 milligram of warfarin, you can consider using low molecular weight heparin in the first trimester, then continue with the warfarin. And if patient is taking only less than 5 milligram of warfarin, you can continue till all the trimester. And in case of emergency situation, we have to reverse it, correct? So the treatment for in emergency is, you stop oral anticoagulation, and you have replace the clotting factors. Ideally, we use 4-factor platelet prothrombin complex concentrate, and antagonize the vitamin K antagonist by giving vitamin K. Okay, but end of the day, we have to balance the risk versus benefit. And these are all the tests we use. To each one has got very important value, like hemoglobin says you have to know because there is any hemolysis or not. In case of any prosthetic valve, these battery of tests are very, very important. To summarize, these are all the important history and investigations we have to ensure while doing a prosthetic valve. First, you should know the baseline to know the natural history. Then the patient symptomatology warrants further evaluation. Then you should know about the details of the prosthetic valve and the nature also. Then vitals to frame your anesthetic goals, and patient weight and body surface area, as we mentioned, to know the prosthetic valve mismatch, and remodeling or chamber size indexing, and neurological assessment to know the thromboembolic risk, and anticoagulation data to know whether like you always lie in the therapeutic range, and the medication to plan your anesthetic management. And also you have to do the battery of tests which I mentioned earlier to know how the valve is functioning or the patient is getting any complication to the valve. Thank you. Thank you so much.